Good morning, good evening. Welcome to the Accelerating Hepatitis C Elimination in the US. We're just waiting just a few minutes to allow everybody to arrive. I can see there's quite a few people already, but the number keeps going on. So we're just going to give it a couple of minutes, bear with us, just to allow people to arrive and settle. Hi, Thomas. Okay, seems like it's slowing down a little bit, so I'm going to kick it off. I can see that everyone already is using the chat, which is brilliant. Okay, so my name is Rachel Halford, and I am the current president of the World Hepatitis Alliance. And just for anyone who doesn't know, the World Hepatitis Alliance is a network of over 400 civil society, a network of over 400 civil society and community organisations working across 120 countries. As I've already said, welcome to our webinar tonight, Accelerating Hepatitis C Elimination in the US. Thank you for joining us. I'm actually here, have a co-chair tonight, so I'm really pleased to introduce you to Ronni Marks. I'm going to hand over to Ronni, who's going to take you through, I just saw something come up on the chat around translation, etc., who's going to introduce herself and take you through a little bit more of the logistics. Over to you, Ronni.
Okay, thank you, Rachel. Hello, everybody. I'm Ronni Marks from the Hepatitis C Mentor and Support Group. We are an organization based in New York that provides education and supportive services for anyone affected by hepatitis C. I am also someone who cured of hepatitis C after 3 tries 11 years ago. I want to note that this webinar is being simultaneously translated into Spanish. The translation instructions are on the screen. I'm going to ask that each panelist introduce themselves and provide their name, their job title, their role, and the organization. Who wants to start? Daniel?
Sure, Ronnie. Hi, everybody. I'm Daniel Raymond. I'm the Director of Policy for the National Viral Hepatitis Roundtable, and we're a network of patients, providers, public health leaders, community-based organizations, and advocates working to eliminate viral hepatitis as a public health threat in the United States. Happy to be here.
Jordan, would you like to introduce yourself?
Yes, absolutely. Thanks so much for having me, Jordan Akerley, they, them pronouns. I'm Strategic Director of NHEP CSF based in San Francisco and also co-chair of the California Hepatitis Alliance.
Fantastic. Lovely to have you with us. Who else we've got? Dr. Nora. I can never pronounce your surname, Nora. Can you tell me how to say it properly?
Oh, I would answer to anything really, but you should, it's Tarot. It's a little bit
Right,
French.
thank you.
So you're not alone in struggling with that. So hi, everyone. I'm really delighted to be here. I'm Nora Tarot. I'm a hepatologist, chief of the division here at University of Southern California, and a member of the AASLD's and IDSA HCV guidelines committee. So excited to be sharing with you tonight some new developments in that area. So happy to be here.
Fantastic to have you with us. And Dylan, let's introduce yourself.
Yes. My name is Dylan Moore. I am the director for Viral Elimination Centers, or VEN Centers. That is a mobile outreach program operating under the umbrella of Arizona Liver Health. I am an RN by background, had the good fortune of being asked to start up this outreach program in July of 2023, and also am on the executive board for Hep Free Arizona.
Brilliant. Fantastic to have you with us. Ronni, shall I hand it back to you? Sorry, I looked like your mic went funny. Did it go? You back?
Yeah, can you hear me now?
Yes, we can now. Brilliant. Back to you then.
We are going, so everybody's introduced themselves. We are going to introduce Daniel Raymond, who is going to give you an overview of the introduction of the new hepatitis C bill in Congress and how it will impact Hep C elimination in the US. Daniel?
Thank you again, Ronni. So I'm grateful for this opportunity to talk about what I would call a landmark in policy development in hepatitis C elimination in the United States. This is the first really major proposal to get us much closer to hepatitis C elimination than we've ever been able to glimpse before. And it took a while for all of these pieces to come together, and it also has a bit of a ways to go. So I'm going to just lay out what this legislation is about, a little bit about why it's necessary, what its prospects are, and what are the next steps. So with that, the Cure Hepatitis C Act, or Senate Bill 1941, was introduced in Congress a few weeks ago in the United States Senate by a bipartisan team, Senator Bill Cassidy, a Republican from Louisiana, and Chris Van Hollen, a Democrat from Maryland. This is a proposal for a 5-year program to accelerate, specifically focus on hepatitis C diagnosis and cure. A lot of the provisions really emphasize closing gaps in treatment access. And so states would have the opportunity to opt in to a financing and drug procurement mechanism that would allow them access to the direct-acting antivirals for Medicaid beneficiaries who are typically low income, probably make up the plurality of hepatitis C untreated patients in the United States, as well as incarcerated persons under state and county corrections and the uninsured. Similar provisions around procurement would also affect people incarcerated in the federal correctional system, as well as the network of Indian health clinics around the country. And finally, for senior citizens and people with disabilities who are on Medicare, who would otherwise need to pay a share of the costs of DAAs out of pocket, this would waive those out of pocket costs for that 5-year period. In parallel with that, several billions of dollars would be invested and go out to states in formula that's related to their need and prevalence around building provider capacity, linkage to care. There's some money for public awareness, for training, for all of the different kind of elements that get us closer to achieving that cure cascade. There is also support for advancing the validation and authorization of new diagnostics. Some of these in use outside of the US, but have not received FDA authorization that would benefit the diagnosis and treatment. That also includes hepatitis B diagnostics as a component of pretreatment evaluation. And significantly, it's estimated that the net savings of passing and implementing this bill in a 10-year window exceeds $6 billion. So while the costs of the bill are over $10 billion, the net savings are considerable. So in terms of the need and the rationale for this bill, we've seen significant declines in hepatitis C related mortality since the introduction of direct-acting antivirals just over a decade ago. However, we still have a lot of people, 2.2 million estimated chronic hepatitis C patients in this country who have not been cured. Some projections suggest that number could be significantly higher if we're undercounting people who've been exposed over the last decade related to drug use. That essentially means that we have struggled in America's fragmented healthcare financing and delivery system to get the incentives aligned so that payers, healthcare providers, patients, pharmaceutical companies all benefit from treating more people. So this bill is an attempt to infuse resources to close some of those gaps and realign those incentives so that everyone benefits from getting people diagnosed and cured. It also acknowledges that there are particular subpopulations and settings like jails and prisons, like people who use drugs, who have been left out of mainstream healthcare, people who are unhoused, people living on tribal lands who have been less likely to access the benefits of these treatments. And so it makes some specific attempts to address those gaps. In terms of the challenges, this bill has been introduced in the Senate. The United States has two chambers in Congress, the Senate and the House. So we would need to identify bipartisan co-sponsors to introduce a House version. There could be some opposition that emerges. The majority's party that controls both the House and the Senate. Many members have a generalized aversion to authorizing new kinds of mandatory funding programs, which this bill represents. And there can be some disagreement on federal involvement in drug procurement and purchasing that could play out in the response to this bill. We do not know where the White House stands on this, if whether they are going to take a position, favorable, unfavorable, neutral. And there are a lot of other dynamics playing out in Congress right now that could impact the prospects, if this bill were passed, of its ultimate impact, including changes to Medicaid, including restructuring of some federal health agencies, including some proposals for cuts and layoffs and reductions in the workforce of some federal health programs. There's in politics, especially in Congress, time is always the energy. Congress is not required to vote on this bill or to take it up for consideration or hold a hearing on it or advance it at all. And so there's going to be a need for concerted advocacy to raise and elevate the profile, highlight the benefits, the significance, and the timeliness of this legislation. In terms of short-term next steps, the short-term focus is on building bipartisan support in the Senate through education and advocacy. Right now, the Senate is very much preoccupied with some other matters, so this is not going to be an overnight process. This will be playing out over the next several weeks or months. But educating Senate offices about this in a bipartisan fashion is going to be necessary towards getting it out of the gate. In parallel, we're going to need to do some work to make sure there's a House companion bill that is bipartisan, as well as making sure that different kinds of stakeholders and advocates around the country are familiar with the bill and able to spread the word and lend their voices to this effort. I mentioned some potential sources of opposition. We'll need to monitor and refine our messaging and address concerns if and as they come up, and remain focused on these parallel developments in the legislative landscape that I mentioned in terms of spending bills, in terms of reconciliation, for their potential impact on the feasibility of implementing this bill. ASLD, the American Association for the Study of Liver Diseases, has a great action alert here that I've linked to for people in the United States who want to let their senators know about this bill and call upon them to support that. This link makes it very easy to do that. And I know there's a lot more to talk about, but I'm happy to stick around for the Q&A section.
Thank you, Daniel. Next, I would like to introduce Dr. Nora Terrell, who will give a presentation on AASLD's updated algorithm for hepatitis C testing. Nora?
Wonderful. Well, thank you again for inviting me to participate. I'm excited to share with you some of the latest changes that we've made with respect to the, let me just stop the share here. Let me get my slides. That give me 2 seconds. Okay, can you see them? You're seeing part of it, I guess, right? How about now? Are we good?
Perfect.
All right, awesome. Thank you so much. Okay, so thank you all. And what I'm going to try to do in the next 10 minutes or so is just update you on some of AASLD's new algorithms around HCV testing in the context of a model that's focused on test and treat. So you all are very familiar with this move towards really decentralizing the care of hepatitis C, kind of bringing care to where the patients are. Just to remind you, the AASLD IDSA, as in WHO and others, recommend treatment of all individuals with chronic hepatitis C. And we want to make it as simple and as accessible to the patients that have hepatitis C as possible. So the idea is to do a simple point of care diagnostic, some simple assessment of disease stage, cirrhosis, no cirrhosis, and then prescribe. And increasingly, the emphasis is on trying to do all of that within a single visit. We've already gone through processes of eliminating the need for a genotype, of simplifying fibrosis assessment to a blood test as opposed to imaging or other things. And there's been very nice data that have showed that we can do minimal monitoring on treatment in order to get good results. So all of those have kind of brought us to this point. But one of the major changes, at least in the United States, that happened in mid-2024 is we had the first point-of-care HCV RNA test that became available. Many of you are familiar with this gene expert test, but just to remind you, it's a test that's highly sensitive for detecting HCV viremia and also highly specific. It's done with a finger stick, which makes it very something that's very desirable from the point of view of patients. It takes about an hour for the result to come back. And there are lots of studies I'm showing on the table on the left that show that when you have a point of care test, and especially when you can link it with treatment, that you can really improve the cascade of care and ensure that more people are moving from diagnosis to treatment. Now, there are now recognition that there's some upfront challenges with respect to implementing this point of care test. There's some costs associated with the upfront cost for the machine itself and the purchase of the cartridges. But I think it's been shown that this is something that can be very beneficial in terms of thinking about HCV elimination, particularly here in the US, but I think this has much bigger global implications. And so it was really this HCV RNA point of care test that prompted the AASLD IDSA to put forward a more simplified guidance. And I just want to highlight that there's kind of two ways to think about incorporating this new point of care test, and that we understand that this isn't for every clinical setting. It's not for every patient population, but there are some for which it really is going to be game changing. There's recognition of a two-step diagnostic algorithm where you do a point of care antibody test first, and then only those that are positive by the antibody test then go on to get the HCV RNA point of care test. The advantage of that is that it's generally less expensive because you're only testing those that are positive for antibody. But the downside is that you might be missing individuals that are very earlier in their infection before they develop antibodies. So in some populations where we want to make a diagnosis of early infection, this could be very relevant. And obviously, when you do a diagnostic test where you do HCV RNA testing as the diagnostic test, the advantage is there is that you capture those early infections, those that are viremic but not yet have antibody, and it allows you to make that decision about, I have a patient who's infected, now let's move on to thinking about the treatment component. So that's sort of the major advantage of this point of care RNA test. Now, I mentioned that it may not be applicable to all settings, and this is a very nice, I think, summary of kind of how you think about whether point of care HCV RNA testing sort of fits into a patient population or a target population you're interested in. I think those with high prevalence of HCV RNA of viremia, it makes sense to have this kind of access, especially those where new infections are occurring. Those in which you really have difficulty encountering them, where you want to take advantage of that encounter to make the most of it. I think that's a very kind of important setting of thinking about point of care testing. Obviously, people who have difficulty with access of phlebotomy, this is a finger stick test, so that's very simple. And then there is something around volume that is important from the point of view of making this cost effective. But those are the things you'd have to think about, and is really just the preamble to setting you up to look at the new recommendations in terms of the test and treat guidelines. So now I'm laying that out for you here, and you'll see at the top that there's now this focus on a point of care test. So we would use something like the Gene Expert test, HCV RNA testing. Additional testing that's needed is we need to know about HIV status, we need to know about pregnancy status. So those are also point of care tests, those should be done. And for those individuals that are HCV RNA positive, then the next step is that you would, and I'll just point out on the left there that I'm talking about doing sort of diagnosis and treatment in kind of this one visit. But I'm also going to just highlight that this algorithm, this simplified algorithm, could also be very useful for patients who present to you who already know their status in terms of viremia. And then you can very quickly plug them into this very simplified approach. So, you know, a lot of patients are out there, they've already been tested, they had an RNA test done a year ago, they still haven't been treated. If they present to you, you can also consider this very streamlined algorithm. So you've made the diagnosis, they're viremic. Now you need to stage them. And here we are emphasizing that you just use history and exam to help you out here. So you check to see if they have any signs of cirrhosis. You check to see if they have any history that would suggest cirrhosis. And if they do not have that history, then you would sort of make the plan that I'm going to treat this patient. Well, importantly, med reconciliation needs to occur to look for drug-drug interactions. And then you would draw the labs that would allow you to then go on to do things like the staging, and we have to do HBV testing. But what I will highlight is that you have to order those tests, but you don't have to get the results back, right? So the simplification here is you're going to make the decision about treatment without knowing their HBV result or their FIB4 result, which is your non-invasive test for stage, right? So you're making your decision, you're going to order those tests, but get them started on treatment, okay? And it's only the patients where they either have a history of cirrhosis or history of liver decompensation or complications where that patient really should go to the specialist, or if you have patients who have a medications that are going to be challenging in terms of putting them onto either glecaprevir for prentisphere or sofosbuvir for valpattosvir. But this is this simplified approach. So in one visit, you're going from making the diagnosis of viremia through to prescribing their treatment. Now, a little bit more about the HBV component. So I mentioned that you're going to draw the test for the Hep B. They're going to start their Hep C treatment, but then of course you're going to get that Hep B result back at some point, maybe days, even a week later. What do? Well, if it's positive, then you have to make a decision about, okay, I may need to start treatment for hepatitis B in this patient or monitor them differently. And that probably needs to be done in conjunction with someone with HBV expertise. But the vast majority of patients will be negative for hepatitis B, right? Because it's relatively uncommon. It's in the population of HCV infected individuals. You know, it depends on where you are in the world, but at least here in the United States, it's maybe 1 to as maximum 10% of patients who might have Hep B. So the vast majority of people, you're going to do the test and it's going to be negative. And then you really don't have to do anything further, just continue your treatment for the hepatitis C. Now, I want to just show just one of many, many studies that have shown that this idea of being able to do the rapid test and then quickly get them onto treatment makes a difference. This was a study done in an opioid treatment program. It was just presented at the liver meeting last year. It's a randomized study where they sort of did this on-site diagnosis treatment versus diagnosis and then refer or go to another site. And clearly, we all know this. If you do a sort of one-site test and treat, you get much better treatment uptake, and ultimately that translates into more cures. Now, there's one other aspect of the new guidance that I wanted to share with you, and that is the simplification at the end of treatment. So, you know, we have this new algorithm of how we can get patients onto treatment in that first visit. They're going to complete their 8 or 12 weeks of treatment. And then the new algorithm says that we can assess for SVR 4 weeks after completion of treatment rather than waiting 12. And that's because often, again, these patients are difficult to us keep engaged, perhaps, and we were kind of losing people to follow up and not knowing their status. So we now know that really, if most patients are going to have have a relapse and not of their hepatitis C, it's going to happen in that first 4 weeks. So now the new recommendation is test for SVR at week 4 or beyond. So that allows you to kind of very quickly make that assessment. And I'll just remind you again, that's then the post, SVR, there's still an important component of knowing if they have cirrhosis or not. And remember, you're basing that on that FIB4 test that you're ordering after you start them on treatment. But that FIB4 test, if it's greater than 3.25, then that's a patient who likely has cirrhosis and should be in a surveillance program after cure for their cirrhosis. But if their FIB4 is less than that, then that individual doesn't need any further follow-up with respect to liver disease. They may need further testing in terms of monitoring for new HCV infection, depending on the clinical scenario. So I hope I hope this is clearly for you a way to further streamline what we're doing in terms of diagnosis and treatment. I think now we see there's multiple ways to get a test done, but now we have a point of care HCV RNA test, which really should provide us a new opportunity to do this test and treat. And I think Daniel highlighted very much that we're hoping that we're going to have the resources really to continue to sort of expand our elimination efforts, and having this point of care test in more settings where it makes sense is an important component of that. The new aspects of the algorithm that I just want to remind you of and just hone in for the conclusion here is the hepatitis B surface antigen is the one test, at least in the United States, that we don't have a point of care test yet available. So that's the test that you would order on that first visit, but you don't have to hold on the treatment and wait for the results. You can get the result later and deal with the hepatitis B while they're on their HCV treatment. So you can still do diagnosis and treatment of hep C in one visit. Okay. Same with FIB4. You just do a good history. And if they don't have anything that points towards a diagnosis of cirrhosis, you could again initiate treatment, get your FIB4 result later, and then make a decision about their follow-up after cure. Needs good history taking in order to make sure you're getting that information. Of course, med reconciliation is one of the key elements of that final component of starting someone on treatment. But this is a minimal monitoring kind of an approach. And now, importantly, SVR can be determined at 4 weeks after they complete treatment or anytime thereafter, therefore kind of truncating the entire time you need to have that patient sort of under kind of close care and follow-up. So with that, I'll close, and thank you very much again for inviting me.
Thank you so much, Nora. Brilliant, absolutely brilliant. I did notice that there's quite a few comments that had been coming through. And just to remind everybody, there's a Q&A box there and there's a chat box. So, and we do have, after our next two speakers, we will have a space for audience to ask some questions. So if you don't want to put it in there, we will have some space later but you can actually put your camera and ask some questions. But it gives me great pleasure now to introduce you to Dylan Moore from the Venn Centre. And Dylan's going to be sharing insights on addressing challenges and linkage to hepatitis C treatment and care. Over to you, Dylan.
Perfect. Thank you so much for the introduction. And I am very fortunate to follow Dr. Terrell here that outlined a lot of the processes that we are implementing within our Venn program. And thank you again for having me. This opportunity is certainly a privilege. And want to say for anyone that has seen me present in recent weeks that there will certainly be some overlap in this presentation. So thank you for putting up with me again. But the request today was to present and really illustrate a program model that is in its infancy in reality. It's been 18 months in existence, and how we have been able to scale up a program and some of the opportunities we've had to overcome the barriers that exist in the United States for hepatitis C testing and treatment. And I always have to start these off with giving the true recognition and a shout out to our Venn staff and employees, from our outreach coordinators, our case managers, our prior authorization team, the providers themselves. They are the heart and soul of this program, and it's their passion for the communities that we serve that truly allow us to overcome these barriers. So with that, I'm going to give a brief background on why we're here, how we started, why we decided to start this program. And so Arizona Liver Health was started in 2017 by a group of hepatologists and infectious disease providers to form an outpatient hepatology program. And combined, they have decades of experience with hepatitis C elimination and treatment. But looking around the time frame 2021, ADHS actually reached out to Arizona Liver Health leadership because at that point in time, Arizona had received a failing scorecard for its efforts to test and treat hepatitis C across the state. And so they really wanted to figure out a way to work together and be able to scale up what was happening within Arizona Liver Health and the rest of the programs treating hepatitis C in Arizona. And with that, Arizona Liver Health was granted 340B status for a funding opportunity. And dissimilar to a lot in the majority of states across the United States, Arizona actually does not carve in, or we do not see any savings for 340B status for Medicaid patients, which is significant because that's about 80% of our patients. And without seeing savings from that, we're still able to have the funding and the resources necessary to scale and grow this program and truly treat the vulnerable and unserved populations across Arizona. All right, so for just an overall picture of Arizona, we're looking at somewhere around 90,000 estimated cases. And with that being said, Arizona Liver Health at this time frame coming into that partnership with ADHS was the leading treater of hepatitis C in Arizona, was only treating about 150 patients annually in the brick and mortar clinic. And then through telehealth and consultation in more of the rural areas, about another 50. And so leadership was very aware that something needed to change. The providers that have been working with hepatitis C and are very passionate about hepatitis C work as well knew that we needed to do something, kind of shift the landscape towards providing more opportunities and really give anyone that was interested in care the ability to access it across Arizona. And so with that, we developed this outreach program that is called Viral Elimination, or VEN centers, with a true goal and objective primarily of eliminating viral hepatitis in the state. And so when we sat back and looked, and I know this was kind of the presentation, was to look at the barriers and how we overcame them. 10 minutes, tough to really dive into a lot of these. I will certainly be present in the Q&A and we'll have my contact information up afterwards. But looking at these things that we're all very well aware that they still exist in where we're at in the healthcare landscape, the stigmatization, whether it's in the communities or within our healthcare system itself, is still there, even just for testing and awareness that's still there. Treatment misconceptions over the last 18 months, I have been blown away by the number of not only community members, but providers themselves that are still, their awareness of where we're at with hepatitis C treatment is still interferon. So education, not only within the healthcare system, but within the communities is paramount. Improving access to care is apparent and evident there, of making sure that anyone and everyone interested in care has the ability to actually access that care. And so growing our basically our ability to be out in those areas. Decreasing treatment process steps and barriers. Dr. Teralt again spoke to this. Thank you for that. And improving patient tracking methods. If I could put a pin on anything that is the most important in what we are doing, it is certainly the case management, because this is something we know that somewhere around 40 to 50% of individuals are aware that they are living with hepatitis C and have likely engaged in an attempt to get treated at some point, but have fallen out in that care cascade. Case management is so impactful in ensuring that we stay engaged with those individuals and ensure their success. Every good project needs a story. You have to have a why, whether it's personal or professional. And for us, it really is the community members. And this is Santiago. This is an individual that I happened to meet that has a very similar story to so many people. His story was not unique. And that's something that we aim to change. He had known that he had hepatitis C for over a decade, had tried to get treated 3 separate times, and the same reasons we have all heard historically, too expensive, that their fibrosis scores weren't high enough, that their RNA quant was not, or was too low. And he had given up on the fact that he was ever going to get treated, which is something that is the true objective of our outreach program, is to change that conversation. And bringing it back, so Arizona Liver Health exists across Arizona, primarily in the central region where we see the majority of the population. But we had brick and mortar clinics across the state that had access for hepatology referral, and we still weren't seeing that engagement. And so, as mentioned, the goal was to really expand access to care. And our mobile offerings have really provided that opportunity to where these are not representative of all, but this is where we are out on a consistent basis, offering education, testing, treatment across the state. And again, as Dr. Terrell mentioned, so this is something that we've all come to know too well. I'm very thankful for the ASLD guidelines for simplification of the overall treatment, and especially the test and treat model now, because we know that every touch point that we require or request of an individual is another likelihood for them to fall out of that care cascade. And so from the inception of this program back in July of 2023, this is how we have this is how we have provided our care to our communities. So whether we screen you reactive, or it's somebody that knows that they've been living with hepatitis C, that we're doing a provider visit, a phlebotomy draw for confirmation, and then making sure we're getting all of the paperwork and information necessary so that we can stay in touch with that individual, whether or not they're sheltered, whether or not they have a phone, but we're developing a plan with them that we are going to be able to relocate them in the community. Just some examples here. Always good to throw some illustrations in so you can see what's happening, whether it's out in the encampments, at shelters, providing large-scale presentations for reentry and recovery centers, are truly just out our favorite and my favorite that we term guerrilla testing, just backpacks, boots on the street, out at bus stops on the streets, gas stations, and making sure that even when we're bringing a van and we have that resource, that we're still going to the individuals, because one more place, even if we have a van out there, sure, it's outreach, but we're still requesting them, or that the individual come to us. And so trying to flip that script. And here for 2025, we have more numbers, but for 2025, this is representative of our outreach from the OraQuick antibody testing out in the field. And thanks to the studies that have taken place globally for the 5-minute read time and their efficacy at that point in time, we've been able to make this process even more efficacious. And you can see, so from recovery programs, homeless services, reentry programs, our at-risk communities and vulnerable populations that we truly try to get out to regularly, how many unknown cases we've found through these tests, but then also how many individuals that had been known to be living with hepatitis C that we were able to re-engage successfully. And again, very thankful for this step, and this FDA approval within the United States. So we, again, we're fortunate to have, through COVID, 2 gene experts for Arizona Liver Health that had been unused for about the last year. And so when this test saw approval, we were able to figure out a way that we were going to implement this. And I will be the first to say that I was very skeptical of how this would actually elevate our program, and have been happily surprised here with the implementation that we've seen and the success out in the community. So from April 1st to June 13th, that was the test expiration date that we had, a total of 126 individuals tested. And anecdotally, what you're seeing out there and subjectively, just the appreciation and the engagement from that real-time awareness for individuals. Not only were we finding a lot of people that had thought they were living with active hepatitis C turn out that they had seroconverted, but we were able to provide those results real time. On our end, the most significant contribution that I've seen for this is that in Arizona, we're looking at that 48 to 72 hour time from phlebotomy and serum collection and processing by the lab, that we've seen that reduction of being able to, in the moment, write that prescription. And we're working with multiple pharmacies in Arizona right now to try to go from either same day or next day handoff to real-time handoff in that moment of discovery. In this, so more than anything, looking at, there is not a one-size-fits-all solution for hepatitis C elimination. And with this, it really is about the partnerships, the collaborations, layering different services so that we can encompass what works best for any individual that's in need or seeking services. And you can see here that our SOC, our brick and mortar, has stayed pretty consistently over the time that we've implemented this outreach model in those that are prefer or able to get into clinic. But this large and profound gap that we've seen in this increase in individuals that have been linked to care from our outreach capacity that they would not have been, or most likely not have been otherwise. And so to bring that story full circle, Santiago, and this is prior to the point of care. So within 30 minutes of me opening my mouth, we had his entire process completed, lab draw, provider visits, had all his information necessary, and we were able to get him linked to medication and hand off medication directly to him within 3 days. I'm very happy to say that he is cured at this point in time. And this is something that with the Cepheid point of care RNA, we're seeing those decreases and those increased uptake in overall treatment successes. So hoping to have more data as we start to use this into the future, and happy to report when that time comes. But to close that off, there still is a lot of pessimism about the reality of hepatitis C elimination. And to me, this isn't theoretical. It's really joining arm in arm with our communities and as healthcare providers to be able to show up where we are needed and be present enough so that when someone is ready to engage in treatment, we are there for them. Thank you again. That's what I've got.
Thank you, Dylan, for such an excellent presentation. Arizona is very lucky to have you all. I think for all of us that work in the communities, we are experiencing a lot of the same issues. I want to introduce our final speaker, last but not least, Jordan Ackerley, who will give an overview of the community organization's critical role in addressing challenges to achieving hepatitis elimination. Jordan?
Thank you very much, Ronni, and I appreciate the opportunity to take the baton from Dylan and close us out today for the Q&A. All right. Is everything all right with my slides for you all? Okay, fantastic. Like Ronni said, my name is Jordan Ackerley, Strategic Director at NTEP CSF and co-chair of the California Hepatitis Alliance, and I'm really glad to be here with you today. The presentation that I'm going to be sharing is from the ground up, community organizations and hepatitis C elimination, and it focuses on the role of community organizations in addressing challenges to achieving Hep C elimination in the US context. And I'll say before joining NTEP CSF, I worked at another community-based organization here in San Francisco, California, where I helped to develop a hepatitis C services program. And I spent many years in providing direct patient navigation in the community and throughout methadone clinics and other spaces. So I come to this work with both a personal and professional investment in its impact. NTEP CSF is a community-led collective impact multi-sector initiative that was founded in 2016 to eliminate Hep C in San Francisco. And what we do is we really bring together people with lived and living experience from public health, research, clinical, and community partner space. And our work is structured through collaborative work groups you see represented here in this graphic that help to guide coordinated action. And what makes our approach distinctive is that community priorities, not just clinical or institutional ones, drive our strategy, funding, and our systems change efforts. So at the center of our work is we believe that people most impacted by hepatitis C are essential to designing the solutions to eliminate it. Community organizations operate at the intersection of systems and lived experience, and that positioning allows them to translate policy into practice and to help bring real-time insight into what's working, what's not working, and why. They help us to stay responsive and grounded in the realities that data alone can't always capture. For example, at NTEP-C, we maintain a publicly available data dashboard. It's something that we've developed in concert with our partners in the public sector and our local health department. And we use this to track our progress. Our community partners, including people with lived and living experience, meet on a quarterly basis to discuss what we call sort of the story behind the curve, which is language from the results-based accountability framework. These conversations help us to make sense of trends, adjust strategies, and ensure our response is community-informed and evidence-aligned. And this data dashboard focuses on community-based testing data, both rapid testing and at this point, RNA testing. We currently don't include point-of-care RNA testing. Most importantly, community organizations build trust with populations who've been excluded or underserved historically by traditional healthcare systems. And that trust is foundational for any effective intervention. And it's particularly important in this moment in the US context that we consider also how we can continue to support the people in these communities, as well as the infrastructure at these community organizations to ensure that they can not only maintain their work, but enhance and strengthen it to respond to nascent challenges. So these community organizations are uniquely positioned to identify barriers that don't always show up in the data, but have a real impact on care. One example is through our community partners and clinician champions. NHEP-CSF learned that our state Medicaid policies limit hepatitis C medication dispensation to 28-day supply, which isn't the full course of treatment. So this is likely an artifact of a cost containment policy that might have been necessary when these direct-acting antivirals first came out. But today, this continues to disproportionately affect people who are experiencing houselessness, increasing the risk of avoidable treatment interruptions, additionally adding to the workload of lots of different providers who are working to support adherence, both from treaters, pharmacists, to patient navigators. So with input from community and providers, NHEP-CSF has helped to frame this as a systems level barrier, and we're now advocating for state level policy change. So this is the kind of insight that community organizations can really bring and the kind of action they can drive, turning these frontline realities into policy advocacy that can expand access and remove barriers, really with a focus on communities that are most impacted by hepatitis C and these systemic barriers to care. And the community organizations don't simply identify the problems, they can also help to design the solutions. And because they're embedded in community and also trusted by program participants, or actually staffed by participants, they often have the clearest understanding of what will actually work and why. An example of this from NHEP-CSF comes from our Community Navigator program, which is a program of folks who are with lived and living experience of hepatitis C, who receive support, training, as well as compensation to embed at local community-based organizations in San Francisco to conduct community engagement, education, and other outreach activities. We approached our community navigators to discuss our plans for hepatitis C incentive kits, which was a response to needs that were highlighted by community-based organizations. What we did was we invited the navigators to weigh in on what really should be included in those kits. So they suggested practical items like floss, dental floss, can openers, portable charging bricks for phones or other devices, and really items that are not usually available through other service providers, but help to meet real needs in the community. And so their feedback helped us to fill gaps in existing services and create kits that were more relevant, dignified, and effective. Those kits are now being distributed through multiple community organizations in San Francisco. And just as important as the outcome, this was the process. We made intentional space for meaningful input early on with our navigators. We treated the navigators as co-creators and not as afterthoughts. And by engaging in this way, we're not only improving one intervention, but we're also building trust, relationships, and a space for ongoing partnership that can carry into future work. And this is a powerful example of how community insight shaped strategy, not just in theory, but in practice. So I've talked about how community organizations are essential to Hep C elimination, but this work really doesn't happen by default. So it takes intention and resources to ensure community leadership is genuinely included and supported at all stages. I included a reflection here for folks, no matter what your positionality, whether you're a decision maker and sort of working in policy space, you're at a community org, you're a treater, just to think about how you're resourcing and centering community leadership in your strategy. In the US context, from my perspective, community organizations and public health agencies are facing unprecedented challenges. But when we stay focused and intentional, I believe we really can continue to make meaningful and incremental progress. That means we also need to be willing to rethink how we work, how decisions are made, and how we build partnerships. Centering community leadership isn't just about inviting people in, it's really about changing the conditions so that partnership is real and sustained across high impact systems. Here are I wanted to share a few of the practices that NHEP-CSF has found most effective for moving from intention to action. First, involving people with lived and living experience at all stages of work, not just at outreach, but in design, implementation, and evaluation. Their creativity and insights help to improve the relevance and the impact of all of our work. Second, invest in relationships. Trust and accountability really do take time, especially working with organizations in this moment that have unique histories, missions, and are facing distinctive challenges. I like to quote Adrienne Marie Brown to say that we really need to be willing to move at the speed of trust and to think that this might also involve going out to organizations versus inviting them in, to really assess sort of where they're at in their journey and how we can effectively support one another and partner to develop a common agenda. Developing that agenda together, really focusing on winnable targets, is really vital. When communities see progress on what they've named, see it on an agenda, it really helps to build trust and momentum over time. And finally, leverage existing networks and relationships to share knowledge and align efforts. I love meeting folks who have lots of energy and are getting ready to go out there and they want to start up their own Hep C initiative. It takes a tremendous amount of work. So I really encourage folks to look at the landscape and the space that they're operating within. Think about, while working in resource limited environments, how collaboration can really help us go further without recreating the wheel. So that can involve borrowing toolkits from patient navigation from addiction medicine spaces, to looking at sort of political movements and how they effectively message or help to sort of move the needle with different decision makers, and really to try to use as many tools that are already created and repurpose them to help drive elimination in our spaces. I really think that's how we can drive this forward, not just faster, but more equitably. And here's my contact information. I think I echo what the other presenters said. I could say much more on this, but really glad for the opportunity to speak with you all today. Thank you.
Thank you so much, Jordan. Absolutely brilliant. And 100%, if we are going to reach elimination, wherever we are in the world, it isn't going to happen if people with lived experience aren't key stakeholders within that. Particularly when you think about a lot of the people that are affected, won't engage if there aren't people with lived experience that are coming and reaching out to them, as we heard from Dave, as we heard from Dylan earlier with the VEN project. That kind of outreach, it's most effective when you've got lived experience at the centre. Thank you to all the presenters, incredible presentations. We've now got some time, hopefully a little bit of time for some questions. If somebody has a question and they just would like to raise their hand, please do raise your hand. I'm not sure that I can see them this side. I might have to ask Viola if she can help us. We've got the whole panel here ready to answer your questions. While we are waiting, there's been quite a few that have come up in the Q&A box. Nora, I wonder if I could ask you just to clarify, there's a few that have come up around whether the guidelines are different for acute or chronic Hep C. And then also there was somebody asking about clarifying the genotyping and is it recommended and in what cases, if that is the case?
So in the new simplified algorithm, genotype's not recommended.
Yeah.
I did see in the question that someone asked very specifically about what if you have somebody with cirrhosis and they're genotype 3, because we all know in the guidelines that there is kind of a special way to treat those patients, but we really are aiming to be simple. So I would say that, the recommendation is don't do genotype. So that's first and foremost. And then in terms of acute versus chronic, the guideline doesn't distinguish these actually, right? Because in part, point of care testing, when we're testing for HCV RNA, we're going to pick up acute infections. That's in fact one of its advantages, is that you will, you're not dependent on finding the antibody. So you're going to get people during that early phase of infection. So that's part of its strength actually, is that we're going to identify individuals in the acute phase, and the recommendation is the same. Our treatment algorithms are the same for individuals who have acute versus chronic hepatitis C, and the new simplified algorithm says we treat them the same. And I think, I'll just highlight that, some people had been concerned about the fact that we didn't really have approval for treatment of acute hepatitis C, and very recently, one of the glecaprevir parentosvir got approval for treatment of acute hepatitis C. But truthfully, from the point of view of guidelines, we've always been perfectly fine treating acute hepatitis C. And so we've never been held back by the label. So I would say to all of you, acute and chronic, treat the same. Algorithm works both ways.
Fantastic, thank you. And there's actually one more question here, and I think probably Dylan, you might be best placed, although it could be you or Nora. I don't know if you guys have seen it, about a screening program based in the emergency department. This is from Lindsay. Unless Lindsay's wants to say the question herself. I can't see any hands up. I'll read it out. It says, many of our patients who are identified as Hep C RNA positive in this setting are lost to follow-up after discharge from the ED. Should provision of DAA therapy, it's actually just disappeared. I can't believe that. The question's actually disappeared. Has somebody answered it? What it was about really was lost to follow-up with in ED settings.
Sorry, Rachel, I think Lindsay just raised her hand, so I just allowed her to speak.
Yes, please. Yeah, that would be amazing. Hi, Lindsay.
Hey, sorry. Yeah, I'm not sure where it went in the chat, but yeah, so I oversee a screening program based in emergency departments. And unfortunately, after we, lose these patients from emergency departments or after discharge, we don't have a lot of confidence that we're going to see them again. And so that has kind of been a lot of our hesitance with providing treatment without having the results back of the FIB4 labs or with hepatitis B labs, because we're very concerned, ultimately, if those are positive, we won't be able to reconnect with the patient to manage them appropriately. So I was just curious, in that context, what your all's recommendations or additional thoughts are around that, given the new guidelines.
Dylan, let me know if you want to take a stab at this as well, but maybe I can just chime in. We're trying to remove barriers, right? And I think the hepatitis B is important, obviously, for lots of reasons. One, it's another cause of chronic liver disease and lots of potential complications, so we don't want to miss that diagnosis. But I really am kind of hesitant to say that you should not act on an HCV RNA if you can't be guaranteed to follow up on a Hep B. I think we absolutely should be obtaining the test and the FIB4. I mean, follow the algorithm and do our very best to identify, continue to follow those patients and ultimately identify if they have hepatitis B. But I really think our goal is really try to remove barriers. So, I mean, if you're 100% certain that they're never going to show up again, I guess maybe you should have some hesitancy. But I think the goal should be we're going to get the test because we know that it's important to make both their stage and the Hep B diagnosis. We're going to make every effort to contact them again, stressing to them how important that is to know, and take advantage of that opportunity that you have there to get them started on HCV treatment. Because I couldn't tell from your question whether you actually start treatment in the ED as well, because that's really where this matters sort of the most, right? Is that you're going to diagnose and start treatment, and then you're really looking to have that follow-up while they're on treatment. So I wasn't sure if you were actually doing that, but if you are, then I would say, the goal is still to try to get as many of those people onto treatment, hoping that you can follow them to get, through the treatment part, and along with that, navigate the HBV issue. So I'm not sure I've answered your question, but I guess what I'm saying is that I would make every effort to do the follow-up, but I don't think a priori not treating someone for their Hep C because you're worried they may not follow up, especially if they're going to be following up on treatment. I think you're going to have an opportunity to intervene on the Hep B as well. I think I would say go for it.
Yeah. And for us right now, it's semi-moot. We're not doing point of care testing in the ED just because at that scale, it's really not practical to do a finger stick on that many patients.
Sure.
And it takes us a few days to get the RNA back as a reflex to the antibody anyway. So often they're gone before we get that RNA back. But that's just been a concern I think that we've had thus far, is just the risk for balancing the risk for decompensation. If they are to be Hep B positive, which I understand that risk is relatively low, versus just going ahead and getting them started on treatment and trying to be as simplified as possible. So appreciate the response for sure. Thank you.
Can I just ask Daniel? I was just going to ask you, Daniel, whether you wanted to. Is there anything in the bill that would allow for funding to run alongside? Because if you've got an opportunity to test people, particularly in EDs, where there's people you wouldn't normally be picking up, is there funding within the bill that would stretch this far for resource? Kind of like Dylan or Jordan talks about, that outreach.
Yeah, potentially. The bill carves out very broadly a funding program that would go out to all states, as well as some specific pots of money for settings like community health centers, where there would be a lot of opportunity if this bill gets passed to both advocate at the federal level on how to design the implementation, but also at the state level on where the money could be best spent. And so making the case that community health worker or patient navigator would be a great investment. Looking at programs, like Dylan's or like some of the groups that are part of NHEPCSF that Jordan works with are scalable, replicatable. That's work that could be done in parallel with the advocacy needed for Congress right now. So I feel very optimistic that a lot of these resource constraint, bottleneck kind of questions, and those things that come up in terms of innovative programs like Lindsay is talking about are fundamentally about resources and political will. And this bill gives us a chance to collectively mobilize in a way that we've really never had before in the United States to remove those as obstacles to doing what we need to do.
Daniel, while we have you, do you feel there's any other barriers to Hep C elimination that we haven't discussed?
Yeah, I mean, I think they're countless. Some of them are not unique to the United States. They just take a distinctive pattern. I was thinking about this. Lauren Sant asked a great question about acute hepatitis C infection that I answered in the chat. And the way that I'm approaching this is that this bill is not, it's a 5-year window to do a lot of things with a lot more resources than we've ever had before. Will it mean that we go down to 0 hepatitis C infections in the United States in a 5-year span? No, but that's not necessarily even the public health goal of elimination. It will potentially mean diagnosing hundreds of thousands more people, including more people during the acute infection phase, curing hundreds of thousands more people than we otherwise would under the status quo. And so I think from that point of view, if we get behind this bill, we'll have 5 years to do an enormous amount of work, learn a lot of lessons, take the best of what we've been able to cobble together so far and kind of throw it up and say, let's take this and run with it. And I think that will position us really well, even if there's still some people that we need to diagnose and cure after that 5-year period.
Which brings me to another question. How can different stakeholders work together to achieve hepatitis C elimination in the United States? And not only Daniel, but if there's anybody else that wants to answer this.
I was going to jump in. I know, Lindsay, good to see you again. I actually met Lindsay and her colleagues, I believe, out of the University of Kentucky at a prior conference, and we had discussed these exact concerns about hepatitis B co-infection. And I know the sentiment from our providers and from Dr. Manch, who's been an expert in hepatitis C for a long period of time, definitely echo what Dr. Teralt said. And the thousands of individuals that they've worked with, that the co-infection rates are so exceedingly low, and the risk is so low that to truly treat this as an epidemic, that we need to move away from that liver disease and more into an infectious disease of how we're treating this in the communities and how we're really trying to move quickly to medication in hand so that we eliminate that fallout from the care cascade. And to jump on the other component about the genotype 2, I love that the recommendations are to eliminate that requirement. The unfortunate circumstances that we require considerable advocacy for are that we're not getting approval. So anything requiring prior authorization still necessitates a genotype. Even though it's not necessary for treatment decision making, we're still beholden to those payer source requirements. Arizona is one that if you look at the map for who has gotten rid of prior authorization, Arizona's reflected on there, but the reality is that we've even recently gone backwards, and that anyone now that has ever been dispensed HCV DAAs is now required to have a prior authorization, even if they never started Medicaid or started treatment or actually had the meds in hand. So if a group ordered on their behalf, never delivered them to them, that patient, if they are that individual, if they are now connected to someone else's resource for care, they are subsequently required to submit a prior auth. So lots of different things, especially in the marketplace, dual enrollment that we're seeing, that are putting a significant damper on our ability to get through these approvals quickly. And would be really interested to hear in the future from Lindsay's program. I think she would be a great one to have on a webinar, and see when you're talking about layering services of working with an outreach program or working with someone that is more community-based to work on that direct and maybe warm handoff even when they're leaving your emergency department or leaving an inpatient unit from the hospital, to make sure that you're continuing that care, even if it's not directly through the University of Kentucky, but that they have someone that can keep them in touch with you.
Yeah, that's definitely an element that I think would benefit us greatly. So would love to talk more about that. Great to see you again too, Dylan.
Fantastic. And I mean, I guess maybe Ronni, you can answer this as well. And you, Jordan, you know, it seems to me, you know, not coming from the US, that there are some incredible areas and pockets of best practice and just amazing work, but it's not consistent. So how do you, as patient, you know, community lived experience groups, how do you, I think something Daniel said just now, you know, that kind of bring it together so that everyone's on the same page? You know, what you do? I mean,
well, with my organization, we try to include much of the people on the ground. We go right to where the people are. We try to, there's such a lack of outreach and education still, even in New York, let alone the rural areas. So we try to bring that to them to make them understand. And as I think it was, I'm not sure who it was, which one of you had brought this up, but there is such a lack of education around. People still think interferon's involved. People know they have it. There's such a stigma involved. They don't want to come forward. There are so many avenues that we must engage with to make people understand how important this is, but especially going to where everybody is. We must meet them where they're at. It's vitally important.
yeah. And Jordan, you know, in terms of the community navigators that you guys, you know, could you tell us a little bit more about how, I mean, I guess two things, how you perhaps try and integrate across other states, but also, you know, in terms of this bill, are the community involved in kind of watching and lobbying with the new bill?
That's a great question. I think to take that. So our community navigators, we've done a lot of advocacy at the local level, as well as at the state level. And I think one of the ways that we've really been effective is by partnering. Not only just sort of seizing the correct political moment, looking for the windows, looking to elevate solutions, and really that we think we can get funded, in particular for around Hep C services at the state level. So we train our navigators. We offer spokesperson trainings to help them to do storytelling and to make pitches to legislators, do a lot of education. And so we work with a California coalition called the End the Epidemics, which really brings together hepatitis B advocates, STIs, HIV advocates, and also focusing on overdose and harm reduction. And we go to the state capitol to advocate for different priorities. And we've had two major wins for more than $15 million in the last 5 years for specifically for hepatitis C, which is very exciting. I think that what's really vital is to set that agenda with our community navigators, to really ask for that, again, have opportunities for meaningful feedback. And then at the community organization level, where many of our navigators may work or volunteer after they complete our cohorts, really bring those organizations together. So for example, we've had conversations about sort of coalescing around incentive guidelines for hepatitis C treatment. How do you incentivize people both from start to finish? We also try to reframe incentives, talk about compensation rather than just incentivizing folks, but really to kind of right size it, but also to make it attractive to a participant who's approaching A, B, or C organization, to make sure they're choosing the organization and the suite of services according to what would really be the best fit for them, versus sort of a survival motivation of like, they offer $50, they offer $75. So we're really helping our community partners to be in conversation with one another. And I'm happy to share out a tool after our webinar that we've built both as a resource, a guideline for within San Francisco, but also a guideline for other organizations who might be implementing hepatitis C incentives in their space.
Fantastic, thank you. And just, can I ask a quick question, Nora, about the about the guidelines, because they are only guidelines, aren't they? So whilst they're AASLD's guidelines, how many states, how do people take notice? So I'm again asking this as someone who doesn't really understand. The States is really complicated compared to the UK, absolutely. So the guidelines, will they be accepted by all states, or is this something that happens very independently, pick and choose?
Yeah, I would say it's the guidelines are there to be used as a resource. It
Right.
doesn't require insurers or programs to align with them, but they often are a good starting point for getting change. I think Dylan's highlighting that it varies by insurer, it varies by Medicaid program. So we know that happens. So states, there's tremendous variability state by state in the United States. I think our hope for a national program is to sort of level the playing field in that regard and kind of make things like, the rules around need for a genotype and access for acute and all of the things that have come up in the conversation, that we could make it uniform in terms of how we're doing it in the US. But that is one of the areas of advocacy that still, exists and is required. When we make these guideline recommendations, then it has to kind of roll through each state with advocates kind of really pushing to get those changes enacted in their state. And that is absolutely slowing down our elimination efforts, and why, as Daniel highlighted, we're all very enthusiastic about a national plan that would help us, hopefully, to have more consistency across states.
So essentially the same as everywhere. It's an incredible tool to lobby, particularly for everybody, whoever you are. Ronni, I'm going to hand over to you a minute. I think we just had our...
Yeah, we just got our warning. I saw it. I just want to thank you all for your amazing work that you're doing, and thank you for your presentations today. And I want to talk a moment about the International Network on Health and Hepatitis and Substance Users, INSU, and just make everybody aware that in collaboration with NASDAD, the Coalition for Global Hepatitis Elimination and the National Steering Committee, which I am part of, have developed these one-day in-person training programs to support people to enhance their existing models of hepatitis C care. They focus on the practical implementation of interventions for Hep C, such as point-of-care testing, peer support, dried blood spot testing, etc. And there are several upcoming symposias and you can see it here on the slide. So please let people know in your community, yourselves. I think it'd be very worthwhile for you to attend, scan the QR code to register. And I'm going to turn it over to Rachel. And as a patient who has cured, I just want to say, I want everybody to have the opportunity to be cured. There's no reason for anyone to have hepatitis C in today's times. Rachel.
Thanks, Ronni, and that's an amazing...
Rachel, do you mind if I jump real quick on to
please
piggyback
do,
off of that? I apologize. Ronni, thank you so
please do.
much. And so the INSHU that's taking place in Phoenix on October 3rd. So Venn Centers is also, so we're co-sponsoring that October 3rd, October 4th. It will be a Friday, Saturday in Phoenix. Venn Centers also hosting Doing It in the Desert. So not only will it be the INSHU practical component of that, we'll have a subsequent day that is a lot more informative on various models of care for hepatitis C and also HIV. And then that Sunday, we're going to give an opportunity for any groups across or that end up attending that want to get out in the Phoenix area and do real-time outreach to learn from one another and support the community. That's going to be taking place on October 5th. Apologies. Thank you for the time. Right.
No, don't apologize. It sounds absolutely amazing. I wish I could come. I guess, I mean, and also just to say, they are incredible symposiums that INSU organise. I want to just finally end. Ronni, you said it brilliantly just now. I think the reality is that no one needs to die from hepatitis C. Treatment is, really easy, really easy. I want to thank our incredible panel and presenters this evening. I think it's been so fascinating, absolutely brilliant. I could carry on for ages more. I need to also thank Halford, who are our supporters of the webinar, and you all for attending. Thank you so much. If you are happy to stay on at the end, there is a quick short survey about the panel discussion, which we'd be really grateful if you would be happy to complete it. But most of all, I just want to say thank you very much. And I think, you know, I think we've got enough here to actually do this again. So thank you for attending. You can pick this up on the recorded session, and thank you to WHA for organising the event. So Viola and Alexandra in the background, and for our wonderful interpreters. So thank you very much. Have a great day or evening wherever you are, and I look forward to seeing you all again. And thank you, Ronni, for co-chairing with me. Thank you.
It was a pleasure. Thank you.